What are the actual goals of knee replacement? I think a lot of people think, oh, I'm just gonna get my knee done because someone said I should get my knee done, but I don't even know what the goals are. So we're gonna talk about all of the goals, or the top 5 goals as a surgeon and what you should kind of have as a patient from a knee replacement. Welcome to Talking with Docs. I'm Dr. Brad Weenie.
And I'm Dr. Paul Salazar. So you're basically answering the questions like, why are you doing this?
Yeah, why are we
going to do this?
Can we just have one very short moment of silence for the end of the Toronto Maple Leafs hockey season?
That's over. and you can play this video again every year because it will be relevant for all time.
It's so sad. In one of our other videos, like about a month ago, I really felt strong that this is going to be the year.
Or you can go in a time machine and play this video since 1957.
No, 67.
67. Since 67, or play it into the indefinite future, where we'll address that question.
All of Canada now is Edmonton Oilers fans.
Okay, so speaking of the Maple Leafs losing, the first goal is pain relief, okay? Pain relief.
Yes.
The first goal of a total knee replacement is to reduce your pain.
Does replacing your knee make the leaf pain go away?
No, not the leaf pain, but your knee pain is reduced.
Right, so people with severe arthritis have sore knees. So when someone comes into me and says, hey doc, my knee's not sore, I'm like, whoa, what? Why are we talking about knee replacement? Because number one is to reduce your pain. And I think what's really important right out the gate is to say, the number one reason that some people are not totally satisfied with their knees is because of unmet expectations. And I think some of it starts with pain. Yeah. So if your goal is to have 0 out of 10 pain after a knee replacement, I'm not sure that that's a realistic goal.
Yeah.
Not because some people don't have 0 pain.
Some people do.
But I would be happy with all of my knee replacements that I perform if pain is drastically reduced. So maybe it takes you from an 8 to a 1. Yeah. Maybe you have a 2. But I think if you're drastically improved, that can still be considered a successful knee replacement.
Or a 10 to a 3.
10 to 3.
Okay. Yeah. So we don't notice how we didn't say the goal is to eliminate pain. Yeah. We don't eliminate your pain. And the other thing we don't do is give you the knee you had 30 years ago when you were dunking.
Speaking of your time machine.
Right.
Yeah.
You're never going to get that knee back. That knee is gone. This is a salvage procedure that we have no other option but to do this, and we want to reduce your pain. That's the first goal.
And I'd say it's very good at that.
It is, and that's actually the main indication or the main reason to do your knee replacement is because the reasons are different than the goals, ironically.
Totally agree.
So the main indication, the main reason is pain.
Number 1, pain relief. Okay, number 2.
Surgeon's pain? No, patient's pain. Okay,
number 2, range of motion. Doc, my knee is really stiff. I want to get a knee replacement so I get better range of motion.
This is a funny one, okay? Because we do want to improve your range of motion. If you have really horrible range of motion, like you can't bend your knee at all, we can improve it. Yes. However, typically, you do lose a little bit of range of motion with a knee replacement. See how weird this is? Although that's one of the goals, we actually lose a little bit of range typically with a knee replacement.
Right, so when we talk about range of motion, it's usually measured in degrees. And it really ranges from being perfectly straight. So if you're lying down, the back of your knee is flat on the bed or the ground or whatever you're lying on. Yeah. And then bent. I mean, the highest kind of physical possibility is probably in the 140 or 150, depending on how thin you are. Yeah. So what I would say is some people lose both ends.
I have a model to show it.
Yeah, okay.
Straight, extended, that's your knee, bending it.
Very good. It's very good.
Extension.
Wow.
90 degrees of flexion.
Welcome to high tech talking with docs.
All right.
That's very cool. What I would say is that
easy.
People can lose range of motion on both ends. So they can not have full extension. So that's what's called a flexion contracture. And this can be a problem for when you're standing up straight. So if you're standing, your knees typically lock. They actually maybe even go a little bit hyperextending. Yeah. This allows us to use very little energy when we're standing.
Horses do it very well.
They do.
Because they sleep standing up.
Yeah.
They lock their knees.
It's very interesting.
Don't try sleeping standing up at home.
Interesting tidbit. But if you stand right now and bend your knees 15 or 20 degrees and stand there, eventually your quads will get fatigued. Yeah. So I would say surgery is quite successful at drastically reducing or potentially eliminating what's called your flexion contracture, getting you perfectly straight. Yeah. The tricky part is the bend, because there have been good studies that show the biggest predictor of your amount of flexion or bend after a knee replacement is your amount of bend before the knee replacement.
Yeah, preoperative range of motion.
So if you have a very stiff knee, I would say often we can improve it a little bit, but I think getting back to a normal range is not, it might be attainable, but it's not necessarily guaranteed.
Right.
Would you agree with that?
I'd agree, and one of the complications of knee replacement is stiffness.
Stiff knee.
So we've said goal is improved range of motion, but some degree of range of motion is the goal. Being able to bend your knee.
Functional range.
Yeah, and some of you may have a little bit of a flexion contracture. You know, you mentioned you often get rid of the extension.
Yes.
Get the extension back, but sometimes it just doesn't come back.
But even if you went from a 30-degree contracture to a 5-degree contracture, you will notice a significant improvement. Okay, so number 3, coronal alignment. So this has nothing to do with corona.
No, or the coronavirus.
Or the coronavirus.
Thank God.
Why
we don't mention that
Why
anymore.
you just mentioned it?
It's like Voldemort. We don't talk about it.
Don't talk about the pandemic.
No. That's in the past.
That's in the pandemic. Please no comments about the jab or about the vaccine or anything like that. Okay, so what we're talking about is whether or not you are bow-legged,
Like
or have
9 out of 10 people with arthritis.
or have what's called varus alignment, or if you are knock-kneed.
Like 1 out of 10 people with arthritis.
Or you have something called valgus alignment. So the goal is to get your knees closer to perfectly straight. I'd say historically, our goal is like 0, perfect alignment. There is a little bit of a community who believes in something called a kinematic knee, where we can leave them a little bit crooked in their native crookedness, maybe providing function. We're not sure where the evidence is going to be long-term. But we want you to be straighter.
Straighter than, especially if you're very, very crooked,
yes,
we try and make you straighter.
And the reason is this reduces your pain, it reduces some of the stress on your hips and on your ankles, and we believe, as guys that have done navigation for 18 years, we feel strong that this is going to increase the longevity of your implant. Just think of your tire. If the tread wear is the same on the inside and the outside for the whole life of your tire, that tire is going to last longer than if your tire's off to the side and you have essentially full tread, no tread.
Right, and now depending on the shape of your leg and the ligaments, tissues, the tension, sometimes intraoperatively we decide, okay, I'm not going to make this one perfectly straight. I think this one would do better in 3 degrees of varus. I think this one would be better in 1 or 2 degrees of valgus.
Right.
So there is some nuance there. There is some decision making intraoperatively. But usually we end up straighter than we were before we started.
And I'd also say historically we felt strongly that the error of 3 degrees on either side of 0 was about the limit of functional outcome and preservation of the implant.
Yeah, but even people who do kinematic knees will still, like if someone comes in
they don't
25
want
or 30 of varus, they're going to try and straighten to a certain degree.
So someone comes to you though and says, Doc, I hate being bow-legged. I was a cowboy before and I don't want to be a cowboy anymore.
Yippee-yi-yi.
Can you give me a knee replacement for that reason? What would you say to them?
No, because that's not one of the indications.
It's a secondary goal, I'd
Although
say.
in young people who have severe bow-leggedness and pain,
I know where you're going.
We do corrective osteotomies.
Right.
Where we straighten your leg but don't replace your knee.
Right. Okay, so number 4 is restoring the function and the strength and the stability of your knee, which not only relates to the wearing away of the ends of the bones, but also the associated pain, the associated weakness of your quads, the laxity of some of the ligaments from being stretched out for prolonged periods of time with crooked legs. How do you feel about number 4?
That plays into something that I remember from residency being drilled into my head. Our role is to restore form and function.
Nice.
Right? Form would be that alignment stuff that we talked about, and function. Function is just enabling you to do the stuff in life that you want to do that you couldn't do before because of your knee.
Right.
Form and function.
Right, and that could be your job, it could be your activities of daily living, it could be responsibilities you have at your home, whatever. Just living your life.
Unless your function is something like, I want to go back to doing the 200-meter sprints. No. There's certain functions that you're not going to get out of an artificial knee.
Agreed.
High impact contact sports. No, that's not going to happen. You're not going to be a linebacker anymore. Within reason, we want you to get your function back.
Okay.
That's why I often ask people, what are you doing now?
What's your goal?
If their activities now are better than what I would consider a good outcome after knee replacement, I'm like, well, you're already there.
Like the person that's looking for an improved time in their 5K.
That's not going to happen.
You're like, I think a knee replacement is not the right thing for you.
No.
Agreed. And this is where the realistic goals comes in as far as improving the success rate of the operation from both the surgeon perspective and the patient perspective.
Yeah.
Okay, the last one, honestly for me, is one of the most important goals, is improving your quality of life.
Yeah,
which I think the first 4 accomplish.
That's right, and it's vague, but just do you feel like the quality of your life is really, really poor right now because of your knee?
Right.
Then replacing your knee might help your quality of life.
Right.
But often I'll have people coming in, with their knee replacement, they're expecting their back pain to go away, their hip pain to go away, their headaches, their marriage to get better, their job to get better. Like your quality of life is so many factors.
Get better looking.
Right? With your knee, you want to be a knee model.
Yeah.
So there's a lot of aspects of quality of life that we can't touch with a knee replacement. But if your quality of life is no good just because of your knee, or a big part of it is because of your knee, then we can improve your quality of life.
Right, and I think what it does is people that have chronic pain are unhappy, unfortunately. It's hard. It's a hard kind of cross to bear. So when you take that away, people get happier. They get to be more functional at their job. They get to be more present for their families. I hear so many people, I went on vacation, and my husband or wife, they wanted to walk in Portugal or something like that, and they're like, I stayed back at the hotel because my knees are too sore. So if you can do more things that give you joy, which I think we all need to focus more on, just finding whatever your joy is, and it's usually not going to be in stuff. It's
Probably not talking with docs.
Why would you say that? Come on.
Well, maybe.
Leave a comment if we provide you with joy. But I
joy.
think improving your quality of life is a big part about having less pain and doing things that you like to do, spending time with people, being connected, all of those kind of pillars of health.
And if I'm carrying too much weight, and my knee replacement's going to reduce my weight?
So I think it's a hard maybe. I think there are good studies to show that I would say it is not a successful weight loss measure or intervention, but sometimes a specific subset of people whose activity is truly limited by their pain, those people become more active. But I think it's more about choosing to be active and then getting your knee done and then being more active.
My answer would have been no.
Yeah.
Personally, knee replacement I don't think is going to reduce your weight. And a lot of people come in saying, well, I can't exercise, I can't do my stuff, so if I replace my knee, I will lose weight. Yeah. The answer is no. Our data shows that you probably will gain some weight.
And unfortunately, my experience says that too. Like you can, you remember the people. Yeah, it's more about lifestyle choices. Not that you won't make decisions later on that help you lose weight or that you can't lose weight. You can, but it's probably not specifically related to your knee.
And now, having said that, there's a lot of factors that might lead you to have a poor outcome with a knee replacement, and we don't know those yet. There's active research going on to try and determine what factors are there that will tell this person they're not going to have a good outcome. Yeah. And we just don't know those yet. No, but we're trying to figure them out.
There you go.
Why? Because does everyone love their knee replacement?
Nope.
What percentage or what do you tell people? You may not. There's a certain percentage, a certain number of people, one sort of number that comes up in all the studies internationally. That says these people may not be totally satisfied with their knee replacement.
So 1 in 5.
1 in 5.
So what I'd say for knees specifically, I'd say a lot of people like their knees. A small percentage of people love their knees, and then some people are not totally happy. And it's not that they would say, I'm not better than I was before. So because I think honestly, almost every single person in my practice would say I'm better than I was before, but they're not as happy as they thought they were going to be. People love their hips for whatever reason. They love their hips. They like their knees.
Who doesn't like their hips?
Yeah, everybody loves their hips.
But the knees, up to 1 in 5 people don't love their knee replacement.
Which is unfortunate and frustrating. To the point where we've talked about this before, you go to a conference, there's always a talk on the looks good, feels bad knee. So the x-ray looks fine, the knee moves well, patient's not happy.
All right. So those are the goals of knee replacement. Why we do knee replacement, what we're trying to achieve.
So consider these when you're making a decision, having a conversation with your spouse, with your doctor, with your family doctor, with your surgeon, whoever. And now you know.
Remember the main indication, the reason to do it is pain.
Pain. Number one is pain.
Not because your friend said you're limping.
Oh, I hear that all the time.
Yeah, they say I'm limping.
Stop talking. Don't talk to me about my knee. It's fine. If you like this video, please like it, subscribe to our channel. Send it to someone you think is contemplating a knee replacement.
And remember, you are in charge of your own health, and you are in charge of whether or not to replace your knee.
100%. We'll see you next time.